For the vital signs, we have Clerk Yaco and Clerk Villaruel. We have 5 vital signs: the heart rate, respiratory rate, blood pressure, temperature, and autosat. The following table serves as a guide to check if the obtained vital signs are within normal range. Always correlate the obtained measurements clinically. Place the pulse oximeter on the finger of the patient. Make sure that the probe is well positioned on the finger, not too tight or not too loose. Oxygen saturation is lower in the immediate newborn. Beyond this period, an oxygen saturation of less than 90 to 92% may suggest a respiratory condition or a cyanotic heart disease. Measurement of the pulse rate is also noted. In obtaining the temperature of a pediatric patient, it can be obtained through rectal, ear, oral, or axillary. The recommended technique varies with the age of the patient. While taking the temperature, we can also check for the pulse rate. Apply gentle pressure to the child's wrist until you feel a slight beat. The radial pulse is felt. Examine it for 1 full minute. These are the normal temperature ranges depending on the measurement method. The respiratory rate is measured in 1 full minute. Based on WHO, the following values serve as the cutoff values per age for tachypnea. The cutoff for greater than 5 years of age is greater than 30 breaths per minute. Observe the upward and downward movement of the chest and observe for any inspiratory or expiratory effort. In taking the blood pressure using the upper extremities, the child should be seated 3 to 5 minutes before measurement. The right arm is usually recommended for standardization. The use of the correct cuff size. The bladder length should be greater than or equal to 80% of the upper arm circumference. Bladder width should be greater than or equal to 40% of the upper arm circumference. The lower part of the cuff is placed 2 to 3 centimeters above the antecubital fossa. The bell of the stethoscope is then placed over the brachial artery. The cuff is inflated 20 to 30 millimeters mercury above the point at which the radial pulse disappears and is then deflated at a rate of 2 to 3 millimeters mercury per second. The first and last Korotkov sounds are measured and recorded with measurements that read to the nearest 2 mm mercury. After determining the blood pressure, determine where the systolic and diastolic blood pressure percentile falls. Using the blood pressure levels for age and the height percentile, determine where the blood pressure of the patient percentile falls. If the height falls exactly in between 2 percentiles, choose the lower percentile cutoff. In assessing the capillary refill time, press your fingers on the patient's nail bed for 5 seconds. The patient's nail bed will turn white. Release your pressure, then count the seconds till the patient's nail bed returns to pink. The normal capillary refill time is less than 2 seconds. If it is greater than 2 seconds, assess for any signs of dehydration.
Hello.
Hello.
What's your name?
Angelo.
My name's Kuya Lance, ha? Okay?
We check the general appearance of the patient, the respiratory rate, the color if any signs of pallor or cyanosis, if there is nasal flaring, grunting, wheezing, stridor, or any signs of obstruction. You also inspect for any masses or lesions, deformities, or defects on the chest wall. Which also check for any signs of retractions or chest indrawing. If there is no lagging of respiratory movement with regular and symmetrical breathing. In auscultation, the ladder pattern is utilized. Listen if there are clear or decreased breath sounds. Here are some of the characteristics of breath sounds, with the duration, intensity, pitch, and the locations where heard normally. Also, we should listen for any adventitious or added breath sounds, such as crackles or wheezes and bronchi if present. For palpation, we form a skin fold locating the 10th rib and check for chest expansion. Check for symmetry and if equal, as the chest is expanding.
Yun nga po, sabihin mo 99 ha. Sige, wait lang.
With a quick, sharp, but relaxed wrist motion, strike the pleximeter finger with the right middle finger or flexor finger. Percuss one side of the chest and then the other at each level in a ladder-like pattern, just like the auscultation. Dullness replaces resonance when fluid or solid tissue replaces air containing lung or occupies the pleural space beneath your percussing fingers. Here is a table showing us if the child is awake, alert, or responds only to verbal stimuli or painful stimuli, or is unresponsive. Here is the GCS scoring in terms of eye opening, verbal response, and motor response.
What is the most likely diagnosis and basis? Based on the case presented earlier, we have come up with severe dengue as our diagnosis. In 2009, the WHO introduced a revised classification scheme consisting of the following categories according to severity: the dengue without warning signs, dengue with warning signs, and severe dengue. Going back on the case presented, our patient has the following signs and symptoms: 3 days history of mild to moderate grade fever, 2 episodes of nose bleeding, vomiting of previously ingested food, physical examination of decreased breath sounds, both lung fields, lung bases, minimal subcostal retractions, muffled heart sounds, laboratory result of WBC of 3.6 and APC of 123. So if we will classify our answer based on WHO, patient has a severe dengue because of the presence of plasma leakage. Plasma leakage is the most serious complication that distinguishes dengue from severe dengue. The immune response against dengue virus begins when viral particles are taken up by cells of the immune system known as APCs or antigen-presenting cells. The dengue virus replicates within the APC, causing it to mature. The mature APC enters an afferent lymphatic vessel where it travels from the site of infection to the lymph node. In the lymph node, the mature APC produces chemical messengers that attract and activate T cells. In a patient with dengue, these activated T cells react and secrete pro-inflammatory molecules such as TNF alpha, interferon gamma, interleukin 6, and interleukin 8. In a patient with severe dengue, the production of pro-inflammatory molecules is significantly higher than in a patient with dengue. When these molecules enter the bloodstream, They help eliminate the virus and might also play a role in plasma leakage. An evidence suggesting that increased vascular permeability during severe dengue were caused by reactive oxygen species, enzymes, and pro-inflammatory molecules that start to break down the glycocalyx layer or the layer that maintains the integrity of blood vessels, allowing plasma to reach the underlying intercellular junctions and leak out into the tissues, leading to fluid accumulation with respiratory distress, which possibly manifested as the decreased breath sounds, both lung fields, lung bases, as well as subcostal retractions. And furthermore, the organ involvement, specifically the heart, which the patient experienced as a muffled heart sound.
According to CDC, the tourniquet test is part of the new World Health Organization case definition for dengue. The test is a marker of capillary fragility and it can be used as a triage tool to differentiate patients with acute gastroenteritis, for example, from those with dengue. Even if a tourniquet test was previously done, it should be repeated if it was previously negative and there is no bleeding manifestation.
Five minutes later.
Plasma leakage is a process in which the protein-rich fluid component of the blood leaks from the blood vessels into the surrounding tissue. If you force pressure in a certain capillary, such as the tourniquet test, you can find that the holes open easily, hence the term capillary fragility. Applying a tourniquet to the upper arm doesn't actually stop blood flow to the rest of the arm, unless you apply pressure enough in the tourniquet to obstruct the brachial artery. So we take the patient's blood pressure. So we inflate the cuff to the point midway between the systolic and the diastolic blood pressure. Then we get the mean. The reason for getting the mean is that we keep the pressure in that point because it means that the arteries are guaranteed to open, but the veins are closed. So the veins are blocked, blood does not return to the heart. This means that blood is going to the hand, but it is not coming back to the heart for the duration of the test. The pressure increases venous capacitance. So blood fills the blocked veins and creates the increasing luminal pressure. If the pressure is enough and there are some dengue antibodies in the capillaries, maintaining some of the holes to be open, blood will come out in the form of tiny red dots. or the petechiae. The test is done for only 5 minutes and the tourniquet or the BB cuff is removed. After the time period, the patient starts to feel pain which increases as time flies. This only means that if there are signs of symptoms, a negative tourniquet test does not mean that the patient does not have dengue. However, a positive test does confirm positive capillary fragility and may support a probable dengue infection.